Hello, dear friends. So, today I have come with a non union of scaphoid fracture. The blood flow to the scaphoid is in a retrograde pattern, which explains the proximal pole fractures when a patient had fall on outstretched hand can leads to non-union and sometimes avascular necrosis of the proximal pole. That is why most of the scaphoid undisplaced fractures are unidentifiable, but once it is identified, most of them has to be treated in a proper way or it will go into surgical management. Herein we have got a patient who had 4 months old non-union of scaphoid fracture, which is identifiable in both AP and lateral views, and it has even gone in avascular necrosis, which is we can see in MRI of his scaphoid bone. So these are the indications for surgery. The principle of surgery is to achieve anatomic reduction and proper central placement of the screw. So here we are operating on a patient with 4-month-old non-union and avascular necrosis of scaphoid fracture. We have taken an incision lateral to the flexor carpi radialis tendon. So we have drawn with a marker and doing the incision. So after incision of the skin, we encounter superficial veins, palmar cutaneous branch of the median nerve, which we have to protect, and flexor carpi radialis tendon that we retract laterally, and radial artery branch of the scaphoid, and radioscaphocapitate ligament, and then volar capsule, and finally the scaphoid tubercle and the fracture at the waist. We can see the non-union of scaphoid waist fracture. We will try to hold the proximal and distal fragment with the two thin K wires of 1.2 mm so that we can retract and do our surgery at the center of the non-union site of the fracture. So it is always better to preserve the dorsal vascular pedicule, especially in proximal pole surgeries.
No, but you can't make out a fracture.
So the structures at risk when we are operating through volar approach are radial artery, palmar cutaneous branch of median nerve, and FCR tendon, which we can properly retract. Now I am taking a bone graft from the distal end of radius. I have made a small box shaped cut using drill bit with K wires, and we have taken that box, and I have taken the cancellous bone from the distal end of radius and placed at the non-union site after thorough debridement and scooping out the non-union area. So after that I have placed K wires from distal pole to proximal pole under the CM guidance. At the surgical site, we can clearly see the FCR tendon that is just below my index finger. After proper placement of K wires and confirming it in CM in both AP, lateral, supinating and lateral view and pronating in a lateral view, I can get proper visualization of K wire so that it is centrally placed. And at the distal pole, the K wire introduction is to be 3/4 medial and 1/3 lateral, the entry point of the K wire. After that, I have drilled the bone, and now we are using a 2 mm complete fully threaded screw, which is not a Herbert screw, it is Acutrak screw. The Acutrak Scaphoid Screw is a fully threaded, headless, variable pitch compression screw, widely used for fixation of scaphoid fractures. It was developed to provide continuous compression across the fracture while remaining completely buried beneath the articular cartilage. As you can see, I am thoroughly fixing the screw, trying to put it within the scaphoid bone, and later I can visualize it and confirm the proper reduction under CM. Here you can see proper placement of scaphoid headless screw within the bone in both AP and lateral views, and good compression with the bone graft placed in the center of the non-union. So thank you, dear friends. I will come up with another good surgical video. Thank you.